Okay, go ahead and next slide. Nothing to disclose other than that I work in Queen Emma Clinic and do collaborative care out of Queens with QCIPN. So currently, collaborative care is for Queens employed primary care practices and any independent practice that's signed an agreement with QCIPN that allows us to share HIPAA protected information and gives us some legal basis for sharing clinical data. I would like to see this expanded to all primary care practices, but there are some legal hurdles that have to be jumped through in order to do that. We currently have 3 psychiatrists, each 1 to 2 hours a week, including 1 child and 1 geriatric psychiatrist, plus psychiatric residents off and on. And we have 3 full-time licensed clinical social worker care managers, and there are more social work assistants and social work interns in training. And so this is roughly what I would call 3 teams. Each team is 2 hours of a psychiatrist and 1 full-time care manager. So we're running the equivalent of 3 teams.
Can I ask you a quick question?
Yes.
I want to make sure I got this right. QCIPN is Queens Physician Group, or is it Queens? It's integrated care, so it's all the healthcare folks on Queens team?
It's Queens Clinically Integrated Physician Network, and it was formed in order to do ACOs, Medicare Shared Savings Program, things like that.
But it's not just doctors, right? It's anybody who is in the group.
It's mainly doctors and APRNs, primary care, but there are some specialists in it also.
Okay, thank you.
So we have a weekly, go back a slide. We have a weekly meeting with each psychiatrist and the 3 care managers. So there's 3 meetings a week to discuss new cases and follow-ups as needed. And the psychiatrists and care managers have access to Epic charts, which is a large majority of the primary care practices we work with. So we can get into their charts and see the patient information that we need in order to come up with a full evaluation. And then the care managers follow with the patient and the primary care practitioner as needed. And we back off and call less if the patient is improving and stable, but we call more often if they're still needing extra attention. Next. Next slide. Okay, the care managers track progress with anxiety and depression scales. They provide counseling to keep the patient engaged in treatment. They're trained in brief psychotherapy modalities such as behavioral activation and motivational interviewing. And the psychiatrist can be called back in as needed, either through the weekly meetings or by phone if there's an urgent question. And patients are discharged and follow up if the problem is essentially resolved. And that's a planned discharge, which we call with a relapse prevention plan. Or they're also discharged if they don't respond to follow-up calls or say they don't want any further follow-up. And sometimes that's because they're better, and sometimes that's because they don't want help. So that could be either one. Or if they move away or die, or if they escalate to direct care with a community behavioral health specialist. Next. Okay, we've trained 185 primary care practices and APRNs, geriatricians, and neurologists in the collaborative care model, which is about half the independent primary care practices in Hawaii. And we cover Oahu, the Big Island, and Molokai. We've trained 6 skilled nursing facilities in Oahu and the Big Island. And active sites are using telehealth to run interdisciplinary team meetings remotely. And we have close collaboration with Queens geriatric team, especially for the skilled nursing facilities. Next. Okay, collaborative care is a model that was developed for mild to moderate psychiatric problems such as depression and anxiety, and it was not intended for psychosis, drug and alcohol abuse, dementia, and major personality disorders. However, as you know, Hawaii has a severe lack of available psychiatrists, especially on the neighbor islands, and for patients with Medicaid and also increasingly with Medicare too. And we want to support the primary care practices, so we have been willing to apply the model to all problems, and we find that it's as effective as direct care for the vast majority, including the severe problems listed above. Next. So financing. CMS has fee-for-service codes in which the collaborative care team submits time spent on each patient per month as an episode of care to the primary care practice. Primary care doctor bills the insurer with fee-for-service G codes for an episode of care. The primary care practice charges the patient a copay. The primary care practice uses most of the payment to pay the collaborative care team, but keeps a little for themselves. And no insurer in Hawaii has made this work yet. Nobody. It's very clunky. Collaborative care programs on the mainland who are all using this fee-for-service mechanism find that at most it covers 80% of their costs. There are also non-fee-for-service funding streams such as accountable care organizations, capitated systems, and grants. Next. So with a QCIPN collaborative care, we have done it in a unique way that no one else in the country is doing. We have negotiated with most of the health plans to pay the program basically a lump sum, an operating budget. Some of them do this by calculating a case rate. Some of them do it by just figuring out what their population is compared to the total population of Hawaii and give us a percentage of our costs based on that. And they just give us a grant each month. Others have special grants, like Aloha Care has one for geriatrics. But in other words, they're all giving the money to the program, and we're using it to fund the program without doing any fee-for-service billing. So we have no billing and collection costs. We don't charge the patients any copay. We don't charge the primary care practice anything. It's all funded through the health plans directly without any involvement of billing. And we make our services available to all primary care practices who are Queens employed or affiliated through QCIPN, and we don't tie our services to whatever insurance the patient has. In other words, once the primary care practice is able to use collaborative care, we'll cover all their patients no matter what their insurance status is, even if they're uninsured, and we don't care because we're not doing fee-for-service billing. And so it's like a community resource that's available to the primary care practice based on patient need with no charge to the primary care practice or patient. And the cost of one module, 1 2-hour psychiatrist and a full-time care manager and some admin and IT support is around $180,000 a year. And we can cover the large majority of the mental health care needs for 40 to 50 full-time primary care practices. That is phenomenally cost effective. The plans that pay us on a case rate basis, what they do is we do keep track of the time we spend as an episode of care, but instead of paying the primary care practice according to the fee-for-service codes, they just give that money directly to us and we don't do any billing. And the administrative savings mean that instead of covering 80% of our costs, it covers 100% of our costs. So we're making the same amount of money work because we have much lower administrative overhead. Next. So how do we evaluate the efficacy of collaborative care? Is primary care practice able to get care for their psychiatric patients when needed? What's the patient engagement rate? Are we seeing improvement in target symptoms such as depression and anxiety? How does this compare to direct referral to community mental health practitioners? How does this compare to co-located care, which means a psychiatrist or psychologist or other mental health practitioner is employed by the primary care practice and working in the primary care setting? And what about intangibles, primary care satisfaction, caregiver satisfaction, confidence that patient is managed appropriately? Next. So this is our latest data on the results of our program. Next. Okay, this is the blue is referrals, the red is enrolled, and the green is discharges. And you can ignore October 2023 because that was after the end of the data collection, and that's why it dropped to 0. And you can see we're averaging around 20 active cases a month, which is the red line enrolled. And the referrals and the discharges all fluctuate, but it averages out to about 20 patients a month that are active in any given month. And with 3 psychiatrists and 3 care managers, that's more than enough staffing to manage that kind of caseload.
So
for
questions.
105 primary care practices.
Yeah,
Yeah.
questions. So you said the blue is referrals. Does that mean referral to you or to referral out?
No, referrals to collaborative care.
Okay, great. So,
And if they're enrolled, they go on the red line. And if we discharge them, they go on the green line.
all right, so it kind of balances out. And
Yeah.
you said, it looks like, well, 30 some months. Okay.
Yeah, but sometimes it's up to 30 active. Yeah.
Yeah, and then we have some interest in the funding. Do you want to talk about that at the end again, or do you want to?
Go ahead and ask a question.
Okay, so Rodney has a question. What's the barrier with insurance companies if it's part of the Medicaid Medicare fee schedule?
The difficulty is that when you use the usual fee-for-service mechanism, as I said, it's clunky. You get poor patient engagement because the primary care practice has to charge the patient a copay. There's a lot more hassle and administrative costs involved doing it that way. By the plans paying us directly and just letting us run the program without doing fee-for-service billing, we love it because there's no managed care going on. The insurance companies aren't interfering with this. It's really a self-managing model because if someone's improving, we have no incentive to overtreat them because we're not billing per service. We just drop back and let the PCP follow up. And if something gets worse and they need us to come back in, we step back in. But all of this is without having to do any kind of billing or cost to the primary care practice.
Let me back up a sec, because I know you love fee for service in general, but there actually is no code for collaborative care, right?
No, CMS has these G codes for collaborative care, but it has to go through the primary care practice because they're the ones seeing the patient. And
So
then we have to bill primary care, they pay us, they bill CMS or whoever the insurer is. It's very.
So are they billing the G code at all?
No.
But they could.
With some of the plans, we give them the data for the G code, and then but instead of the plan paying the primary care practice and them paying us, they pay us directly. That saves us the cost of billing and means that we can make it work for us with a lower amount of money than anyone else on the mainland is doing.
So is there a way to make it work in the system that exists with the G codes? And you said just Medicare, not Medicaid, right?
No, well, Medicare developed the codes, but a lot of the other insurers use them as well. Some of the Medicaid plans have gotten approval to use those G codes, but we have bypassed that. And like I said, on the mainland, everybody else is doing it that way, and they all say the best they can do is covering 80% of their costs.
So
avoiding fee-for-service billing, we're covering 100% of our costs for the same amount of money.
Right, you don't have to do the paperwork too.
Right.
So Rodney says, so once these contracts expire, how does QCIPN continue the model?
We have negotiated with the health plans for this to be an ongoing thing.
Excellent. All right, so they basically kind of assess the cost of the G codes and just pay you that amount without all the paperwork.
Exactly.
Ooh, I love that.
Exactly. Or the way UHA does it is they say, well, our patient population is about, 7% of your total population. So we'll give you 7% of your costs and you cover our mental health needs. That's even simpler.
Yeah. Ooh, okay. Sorry, go on.
Next. This is primary payer. The purple one with 291 is HMSA. The blue is regular Medicare. The green is Medicare Advantage. The yellow is HMSA Quest. The red is HMSA Akamai Advantage. Aloha Care is in flesh colored. Pink is UHA. And then the rest are all smaller. So that gives you a rough idea of our payer mix. We have contracts with HMSA, Akamai Advantage, Aloha Care, United Healthcare, UHA. We don't have contracts yet with Ohana, but most of the rest we have covered. They're helping, they're contributing to our funding. Next. These are the diagnosis breakdowns, and it adds up to more than 100 because some of them overlap. But the purple is depression, the blue is anxiety, the green is dementia, the yellow is others, the red is ADHD, and then there's bipolar, substance use, OCD, alcohol use disorder, adjustment disorders, opioid abuse, schizophrenia, and eating disorders. Next. Reason for discharge. The purple is a planned discharge with a relapse prevention plan. The blue is lost to follow-up. Either the patient stopped responding to phone calls or said they didn't want to deal with us anymore. And the green is we escalated them to direct care with a psychiatrist or other mental health practitioner in the community. And the yellow is other, the red is deceased. The flesh colored is declined further services. And then the rest are moved away, did not engage, or no reason given. Next. So this is changes in the PHQ-9 scores for patients with depression, and when they enrolled, the average PHQ-9 was 14.1, and the last one we got was averaging 8.85, which is a 37% drop in PHQ-9 scores. Next. Same thing with anxiety. Average initially was 11.5. On the last enrolled score was 7.45, a 35% drop in anxiety scores. This is changes in hemoglobin A1C for diabetic patients. The average was a drop of 0.3, which is actually pretty good for an A1C. There was one that was as low as 6.6 point drop in A1C. And I think the reason is because our care managers are contacting the patient frequently, their overall compliance with all their medical care is better, and we're getting results in things that we're not even addressing with our program, like diabetic control. Next. This is ED visits, and the colors are a little confusing. The purple is 1 year prior to enrollment, and the yellow is 1 year after enrollment. And then the middle ones are 6 months before and after. So I would just look at the purple and the yellow. So our ED visits dropped by 1/3. Next. And our inpatient visits also dropped by 1/3. Next. And inpatient readmissions dropped even more. Okay, so let's look at how our results compare with treatment of depression in primary care without a psychiatrist being involved. There's one study looking at response, partial response, and non-response in primary care treatment of depression. They had 688 patients enrolled. 482 completed a 6-month assessment, which is 70%, and 30% dropped out or failed to engage. Our program has a 78% engagement rate. Remission, which means they got to a PHQ-9 score of, I think, less than 8. We had, of the ones who completed the program, they had 22% reach remission, and 15.8% of those who were enrolled reach admission. And our data is 40% reach remission. Partial responders was 152, which is 31% of those who completed. Either response or remission was 54% of those who completed the program and 37.9% of those who enrolled. And our data is 51% of those who enrolled. And non-responders were 45% in the primary care practices. And the failures, which is non-responders plus dropouts, were 59% of those who got enrolled.
Okay, wait, I'm a little confused. Let's see. So when you say of C, is that of the completed 6-month evaluation group?
Yeah, exactly.
Oh, you got Nash to publish this with you. Excellent. Oh no, that was from before. And that's last one. Anyway, ignore that. So you've got, let's see. your numbers are the 688, or that's the article?
Our numbers are in red. Their numbers are in black.
Okay. Oh, I see. So they had 109 remitters
Yeah.
and you guys had 40% less than that.
No.
Okay.
We had 40% of those who enrolled in our program reach remission.
Okay.
The best they did was 15.8% of those who enrolled, or 22.6% of those who completed.
Okay. And then of response or remission, they had 54% of those who completed, 37.9% of those who engaged.
Oh,
And you had 51% of those who engaged.
who enrolled, yeah.
Enrolled. Got it. Okay. Okay. Nice. Any more questions? I know that's a packed full slide.
Yeah, it is. It's hard to make it clear, but yes.
All right, cool.
Okay, next is collaborative care compared to co-located care. So this is looking at practices where they hired a psychiatrist or psychologist in the primary care practice, how they did compared to the primary care physician or APRN managing the care with collaborative care support. And the primary care patients started with PHQ-9s of greater than 10 to qualify for the study. And they were able to engage 43%, of which 118 were in collaborative care and 122 were in co-located care. And the outcome, looking at the reduction in PHQ-9 scores at 12 weeks, co-located care, 14% drop, collaborative care, 33% drop, and our data is 38% drop. So we are doing better than if you have a psychiatrist or psychologist directly working in the primary care practice. The model greatly enhances the efficacy of primary care. PCPs report increased confidence in managing psychiatric problems, knowing they have expert backup if they have any questions. They find psychiatric problems becoming much less stressful to deal with. The care manager gathers a full history and provides frequent patient contact, and basically it takes the worry off the PCP's back. And they also have confidence that they're doing the right thing for their patients because they're using our advice. Collaborative care model is applicable to any specialty consultation that does not require an imminent procedure. This can be used for endocrinologists consulting on complex diabetics, rheumatologists, nephrologists, anything where they don't need to come into the office or the hospital and do a procedure. You could apply the same thing. I've had discussions of this with adult congenital cardiologists, where the patients with congenital cardiac defects need very specialized care. And if they get routine care for their cardiac symptoms, it can lead to serious problems or be fatal. So you really need expert advice, but there aren't nearly enough specialists in adults with congenital heart disease to meet the need. So if you set it up with collaborative care, so you had the specialist consulting to general cardiologists or primary care, you could greatly improve the care, leveraging limited number of specialists to cover a large population. Would work exactly the same way. UHA calls this a medical yurt model, where they say, okay, this is a complicated case. We're going to negotiate directly with whatever doctors are needed to manage it, and we'll make sure they're paid adequately to it, and they just take care of the patient. And this is outside of the usual fee-for-service billing, same idea, where you put your resources, give it to people who have the expertise to deal with it properly, and let them do their thing. Next. That's it. Yes.
Well, that's exciting. Shirley says, I apologize for the late arrival. Searching for the login link was a bit challenging. Oh, I'm happy I got in. So let's see. So what questions do folks have? So your team of 3, it's a 2-hour psychiatrist every week. a full-time social worker. And who's the third person?
There is some admin and IT support
Okay.
from QCIPN.
So basically it's the two, it's the social worker
Right.
and the psychiatrist. So basically the primary care says, oh, I've got this patient that needs psychiatry. They contact the social worker. They talk physically to the social worker, or is it just like a email chart review kind of thing?
Usually by telephone, sometimes by telehealth, and occasionally in person, but usually the primary care practice, the care manager gets a hold of the primary care doctor usually within 3 days of the referral.
All right.
And it's
You-
3 days if it's on a weekend, and on the weekdays, it's within 1 day usually. And
And so
then we have 3 interdisciplinary team meetings a week with 3 psychiatrists. So they present the case to the next available one. So that's usually within a couple days.
Mhm.
So we are giving the primary care practitioner our response within days. Whereas if you tried to refer to someone in the community, it might be months.
Oh, forget about it. Yeah. So basically, do you give them back a written description, or is it just phone to phone to phone?
No, it's written. As the psychiatrist, I get the presentation from the care manager, the full psychosocial assessment. I
Mhm.
have Epic open on my desk. I can look up whatever medicines they're on, whatever their medical history is, whatever I can find out from the chart, and then I
You
give
could look up,
detailed
mhm. Theoretically,
instructions to the primary care doctor.
if they had DNA testing about which medicines are best for that they metabolize best, you would have that too, right? Because it should be an epic.
If they've done it, I would be available to me, yes.
All right. So you have their medical history, you have the phone call from the care manager, or does like
The-
care send you something?
The interdisciplinary team meetings were in person until COVID, and now they're by Zoom.
All right. So, and you're all 3 psychiatrists together in that meeting, or just one?
No, there's 3 interdisciplinary team meetings a week, one with each psychiatrist.
Got
And
it.
all
Perfect.
3 care managers go to all 3.
Got
So
it.
they can
Okay.
present to whichever the psychiatrist is available, or who they think has the right expertise. Like one
Right.
of them is a child psychiatrist.
Perfect.
That's Gary Carlton, so he'd get the kids.
And what I really like is you get the primary care provider gets the written guidelines or suggestions, right?
Right.
So they're only suggestions. So the primary care provider is the one on the hook for the malpractice because they're the ones doing it.
Right.
And then they do it, and then the care manager checks back. Okay. Let's see. Questions. Are there plans to expand beyond QCIPN?
The problem is finding some way to have the legal authority to share the chart.
Even though we have Epic at Kaiser and HPH, it's a different Epic, right?
No, if it's HPH or Kaiser, we could share, as long as you have some legal contract that would enable you to share the data. And because Kaiser and HPH are protective of their turf, they're resistant to that. If they were to say, we want to participate, they would have to sign the appropriate agreements, and we could open it up.
Right. All right. Another question is there any Hawaii state guidance on this billing for collaborative care?
What do you mean guidance on billing?
I'm guessing, but like the way you do it, so you have agreements with the different insurers, so it makes sense that if there were like a billing guide, so like you said, UHA, they look at the number of patients and they say it's about 7% of our patients are about 7% of your load, so we'll pay 7% of the costs.
Right.
Oh, well, another part of the question is, other states have this. Do other states have collaborative care models, and do they have an insurance guide? Because I know we're special because we don't have 100 different insurers. We only have 7. And you have agreements with, sounds like 5.
Yes, on the mainland, they're all using those G codes that CMS set up.
Got it.
And
Okay.
they're all using the fee-for-service billing, and they're all having problems with it.
Covers about 80%, which
Yeah.
isn't enough to make it continue. Okay. So I think the answer is there isn't technically a state guidance for billing, for how to bill this, because it sounds like each insurance company has a little bit different agreement with you.
Right,
All right.
right. It's whatever we can negotiate with them. And mainly what we're looking for is for them to fund us directly and let us do our thing rather than having to do fee-for-service billing through the G
Right.
codes.
Got it.
And within that general idea, there are different ways of structuring that, and we're fine as long as it ends up working the same way.
Mhm. Okay, so for 20 patients a month, you've got 3 care managers or social workers and 6 hours of psychiatry time, as well as some IT and coordination.
Right.
Mhm. And you do better than if there's somebody co-located for a warm handoff, which is amazing.
Yes.
Yeah.
I would say when I was in private practice of psychiatry, when I got a referral from primary care, the chances of that patient actually coming in and following through were no better than 50%.
Mm.
And we're doing 78% because they don't need to establish a relationship with a new doctor. The doctor is still the primary care doctor. They're just getting our backup.
And they don't have to go anywhere, and they don't
Right.
have to spend any time off work,
And they
and they
don't get
don't have
charged,
to call anybody.
and they don't have to get charged a copay.
Yeah. Oof. All right. What questions do folks have? Or a case? So would you be able to give us kind of a case, de-identified, of course, but just kind of an example of what comes in, like say a complicated one?
All right. Okay, let's say you have a patient with a history of several psychiatric admissions for suicide attempts, who has some substance abuse history, but right now that's not a major factor. But they have very unstable relationships, they're very needy, and they basically meet criteria for borderline personality disorder. And they are already on an antidepressant and a mood stabilizer. And they're still often thinking about suicide, and the PCP says, help, what do I do? So the first thing I would say about that type of situation is it's very important not to think of medication as a solution, because it's not. It may reduce some symptoms, it may have an adjunctive role, and it may be a little helpful, but you don't expect too much from medication. The second very important thing is that you need to know the patient's trauma history, because it's highly likely that they have a history of some kind of severe trauma in childhood, usually abuse, neglect, sexual abuse, things like that. Not always, but 90% of the time. And I would say with the medications, it's very empirical, and you want to avoid things that are addicting. But if an antidepressant helps, okay, you can use it. If a mood stabilizer helps, okay, you can use it. But you don't want to give it to them just because they have unstable moods. You want to give it to them because it actually made a difference in their outcomes. So if they say, I'm not as depressed and the ups and downs aren't as bad since I've been on lamotrigine, I'd leave them on lamotrigine. If they've been on lamotrigine for 3 months and it didn't make a darn bit of difference, I tell them to stop it. But it's empirical, trial and error.
So
But
you could kind of give like a if this then that kind
Yeah.
of written. Cool.
I would say, given what they've been tried on so far, this is what I would do next. And this is what I would tell them to expect from it. In addition, there's this particular way you should deal with this psychologically, and that is you want to promote empathy and insight into why it is that they react to things the way they do, or overreact to things the way they do. And that's by making links to their history of trauma. So you say, given what happened to you as a child, I'm not surprised that you feel this way when these things happen to you. And you stop there. You don't try to fix it. You don't try to rescue them. You don't try to send them to the ER every time they're thinking about suicide. You just say, I understand why you feel that way because I know something about what you've been through. And that approach, without trying to overdo it, is the best long-term outcome for borderline personality. And it doesn't take too much of the PCP's time as long as they get it.
Mhm. Okay, let me pretend I'm the primary care provider, and I have a 22-year-old female who recently graduated college. I've been seeing her for about a year, and before finals, she came to me and she said she was really having trouble concentrating. She couldn't stick with one thing for a while. She never really watches a TV show all the way through because she gets distracted, and she's really worried about the finals. And so I started her on Adderall XL, 20 milligrams a day, and that was back in April. And she did well on finals, came back to see me, was very happy. She graduated, but now she's started having panic attacks and feels anxious all the time. And so no other medications, no other medical problems. She has a job. She's working as a medical assistant at a clinic, and she has goals of going into healthcare, and so she is trying to study for the MCATs, but she finds it's just these she gets her heart racing, she gets sweaty just for no reason during the day, about once a day, and she has to leave work, and so she's really having trouble. And I'm wondering, is it the Adderall I gave her? Should I stop that? Should I put her on anxiolytics? So I would call up the, is it care manager?
Yeah.
Okay.
Care manager.
Okay. So I would call up the care manager, like Karen Chan. So I would call Karen and I would say, oh, I've got this patient. Here's her name. Here's her situation. And then Karen would take it from there, kind of thing.
Yeah, she would present the case to me at our next interdisciplinary meeting, which would be within a few days. And then I would give you specific advice. And what I would say about that is it is very difficult sometimes to tell whether anxiety is just anxiety or if it's due to ADHD, because if you can't focus and can't get your tasks done, that generates anxiety itself, but from being behind. So it's hard to tell what's primary anxiety and what's secondary to ADHD. Giving somebody Adderall usually neatly separates out the diagnosis, because if it's ADHD, they can get stuff done and they feel calmer and the anxiety goes down. If it's anxiety, it gets worse. Now, in this case, you gave her, it did help her ADHD, but it seems to aggravate her anxiety. What I would do is just cut the dose down.
Oh, not but cut it down. Have it.
And I would make it PRN. And the reason is Adderall for ADHD works very immediately. It kicks in within 45 minutes. It lasts for the immediate release about 4 hours, for the extended release about 6 to 8 hours, and then it wears off and you're right back to being unable to focus again. So it's perfectly appropriate to target it to situations where you need to focus. So if it's time to study for your finals, you take it. If you're going to the beach on the weekend, you don't take it. There's no reason you have to take it every day. So you can target it to the situation. If you're in school and you need to focus 5 days a week and doing your homework on weekends, you may need it every day or almost every day. But if you're in a job where much of the job is customer service, or once in a while you have to write a report, you only do it for the report. So it's perfectly appropriate to tailor it to situations where you need the focus.
Are there perhaps different ADHD meds that would be less likely to cause anxiety?
They all can, and with sort of long experience, I would say 90% of people end up on Adderall as the one that seems to work the best with the least side effects. So you could try other things, but the odds of it working out better are low.
Mhm. All right. And is the XL versus the regular acting any different?
The XL means that it lasts longer and it doesn't have as high a peak. So you're less likely to get anxiety at the peak with the XL. And it also is more sustained. If someone needs focus only for short periods of time now and then, I'd probably use immediate release. But if they need it for a longer period of time more often, I'd probably use the extended release.
Got it. Okay, perfect. Anybody else have questions like that we can give an example of how how the care model works? 'Cause this is cool.
Hi, everyone. My name is Shirley Davenport, and I kind of have a question. Will we be able to get the file on this care model? But also, I don't work in medication because I'm not an MD or a DO or APRN. I'm a social worker, psychologist, PhD, and non-licensed. So I don't work in medication. My disclaimer of the case was presented, it was like straight to the medication. And I actually physically got nausea hearing that. I had a girl for the last 11, 12 years that was on conditional release from Hawaii State Hospital, Risperdal, couple other medications. I would say kind of like she loved going to the doctor, nymphomaniac, but she had ankle problems, all these medical problems. And she continued to see her psychiatrist because she's, of course, ward of the state with the condition release. And but I had the opportunity to work with her as a sponsor, because when she came to me, like Doctor said earlier, the substance abuse was in remission at 7 years. And the 16th of this month, she celebrated 8 years. But when I got her, she was very suicidal. And one of the ladies that handed her off to me was like, okay, I cannot deal. Almost once a week, she's in Queens, Kakela for suicidal attempts. And I do a lot of motivational and just counseling. I do homework assignments and things, and not necessarily, and I ensure that they continue with what they have in place. So if it's psychiatry, psychotherapy, and care coordination, case management through CARE or one of the state community mental health centers. She was given a document to read every morning, and it talked about no matter how far down the scale you're gone, you are intuitively learn how to handle situations that used to baffle you. And today she never had a job in her life, and she's 44 years old, and she works at the 7-Eleven store stocking shelves. She takes care and bathe her grandmother. And I just hung out with her Sunday night. But she's a prime example, I think, to having medication decrease, keep in touch with the PCP, because a lot of the medication has such horrific side effects. And those kind of things really brought life out in her. And she has not one suicidal hospital or attempt or thought that we had to take seriously medical and police action to get her to some help. So I don't know. It's just that I had to give some hope here around the medication because I physically got really nausea and kind of sick, but I'm okay. Whatever
Well,
helps the client.
yeah, you're completely right, Shirley. I am a prescriber, so I did jump. Well, after a while of knowing the patient was really nervous, and so I gave treatment for the ADHD, but then I got scared that, oh my gosh, I shouldn't have done this. I should take her off of this because I've caused this anxiety. And so she does have a counselor that she's seeing. So I'm sorry I made you nauseous. I neglected that whole part of it, but that is a big part of her treatment. So you're completely right. And in response to your other question, the slides are going to be up on our website. It's usually within a week of the session. So, and then the link is there for the sessions, although it will be changing by next year, we were talking about earlier. Anybody else? Questions or nausea? Sorry.
I just want to add that I think that Shirley's case also is an illustration of if you promote empathy, if you treat a patient with respect, and if you stick with them, what looks like a horrendous situation often levels out and becomes manageable, and they do improve with time. And that's a really good example.
And that is so true. If we could do that for everybody, wouldn't that be great? Everybody who needs it. Of course, then maybe we all need it, but everybody who needs it the most. All right, any other questions? Situations? All right. Well, next week we have one of our very own, Helen Hudson, who is a marriage and family therapist, and she is talking about medical Qigong. So that's going to be very interesting from a therapist standpoint, and to hear one of our own. So I'm excited to hear that. Any last questions? All right. Well, this was great, Dr. Kemble. I know we heard you about 1.5 years ago when it was just kind of starting out and you had some data, but this data was profound. So thank you so much for what you're doing, because it just sounds so helpful. And if we were the first state to set up a payment policy for this, wouldn't that be exciting?
Yep.
Yeah. All right, even for like store and forward consults, that would be really exciting. All right, well, thank you. And we will see everybody next week. Bye-bye, folks.